Thank you all for the opportunity to address you on a vexing clinical issue that we all see in the office, hand dermatitis, and specifically allergic contact dermatitis. These are my disclosures. I work with a number of companies in this space, and I will also be discussing non-FDA approved patch test allergens. Hand dermatitis, as you already heard, is a very broad diagnosis that encompasses many different types of pathophysiologies and diagnostic areas. You've already heard in prior lectures about the epidemiology, and I would just call out here that there are many potential provocateurs of contact dermatitis as it relates to the hands. They may be exogenous, like irritant and allergic contact dermatitis, often interplaying with endogenous causes like psoriasiform dermatitis and atopic dermatitis. Most often we're seeing hybrids in the office, and the spectrum of these diseases can range from acute vesicular contact dermatitis with erosions to hyperkeratotic and fissured lesions. There is some data suggesting that hand psoriasis may have higher frequencies of positive patch tests. For those patients referred for patch testing for suspicion of allergic contact dermatitis, hand involvement leads the list as the singular body part involved. Consequently, when we're seeing a hand dermatitis that has an eczematous component, we might think of patch testing them. We see other areas involved, and also when we're talking about the hands, we also consider the feet. Now, as mentioned before, these polarized textbook diagnoses of hand dermatitis, either eczematous or psoriasiform, they're largely elusive. The reality is we're faced with the diagnostic quandary of either picking the best diagnosis based on comorbid diseases and involvement in more classical areas, right? Pick one of these. Rarely will a biopsy give us the perfect diagnosis here. I mentioned before that there are a number of risk factors, atopic dermatitis being one of the most important one. And I think this is a very illustrative case of an atopic patient presenting to me with all the attendant diatheses for atopic dermatitis, her clinical picture being rather mild to moderate disease with involvement in the antecubital fossae, a little bit on the neck, and of course that stubborn finger involving her hands. And I was quite surprised that her patch tests were as revealing, seeing here many reactions to preservatives and metals, and more importantly, avoidance of them, resulting in her near clearance after years of using topical corticosteroids here. One other additional item is the COVID pandemic, which presented additional therapeutic and diagnostic quandaries for us. Healthcare workers and nearly every person in the world donning personal protective equipment on their hands and their face. And we see irritant and allergic contact dermatitis in these areas. This patient, my daughter, a COVID ICU nurse at the time, presenting with irritant dermatitis of her face and hands. In this North American study, patients with hand eczema demonstrated an elevated rate of positive patch tests. So with this hand eczema, their chances of having positive patch tests to common allergens like methyl isothiazolinone, nickel, formaldehyde, quaternium-15, and fragrance were seen. Recent data from just a number of weeks ago evaluated children. About 14.5% of pediatric patients presenting for patch testing had hand involvement. Ultimately, half of them had a diagnosis of allergic contact dermatitis rendered, while about a third atopic and 16% irritant. Here again, we see common patch test allergens causing dermatitis on the hands commonly. MI, the glycols, the surfactants, the desylglucoside, and items used in emollients like lanolin. So if we look at large epidemiologic trials, what do we see as far as contact dermatitis? In this study of the general population of Danish people, a history of atopic dermatitis was associated with a considerable risk factor for allergic contact dermatitis in those with persistent or incident hand dermatitis. Fragrances and the isothiazolinones were important allergens noted in this study. For healthcare workers, we represent a rather high-risk population for hand eczema. Most are diagnosed with irritant contact dermatitis, but allergic contact dermatitis is not that uncommon, with rubber chemicals, not surprisingly, most often from gloves, preservatives, and excipients in hand cleansers. If we sort of pivot off some of the usual areas we think about and go into our occupational clinics, not surprising that mechanics are a group that suffer from hand dermatitis. Still in these days, males outnumber females in those presenting for patch testing who are mechanics. And again, hands are often involved with allergens like carbamates, thiorams, and preservatives. And these come from things like gloves, solvents, oil and cooling fluids, and lubricants, as we might expect. Now, we've heard rubber a number of times, particularly from personal protective equipment. This is a thoracic surgeon that I've seen who would routinely self-treat with prednisone when he was on call, always had these eroded plaques, and this, not surprising to most of you, a back full of positive patch tests, mostly but not exclusively to rubber accelerating chemicals. And avoiding those resulted in really amazing improvement in his eruption. So rubber, an important hand dermatitis allergen, fall into 5 main allergen categories: the thiorams, the dithiocarbamates, the benzothiazoles, the guanidines like diphenylguanidine, and the thioureas like we see in neoprene rubber. Of late, we're seeing carbamates being used far more in gloves than thiorams were, where that used to be sort of the lead allergen. And patients who were evaluated in North America over a multi-decade period, almost 50,000 patients, a number of them tested positive to rubber, over almost 7%. I think that's a pretty high number. Men, occupational related contact dermatitis, and hands were risk factors for having positive reactions to the rubber accelerators. And when these accelerators were positive, they were considered clinically relevant. And again, gloves were our most common source. So the question at hand, I think, for just a thought experiment, is whether the pandemic, replete with the global use of PPE, including lots of gloves, could translate into a second wave of rubber contact dermatitis in epidemic form in years to come. I have an arrow pointing here to the mid-1980s, where we saw a rather stable activity of thiorams and carbamates, which go back to the 1940s, sharply increasing in epidemic form, coincident in the US with the Centers for Disease Control issuing universal precautions, and then in 1987, additional guidelines called body substance isolation, which advocated for the avoidance of direct physical contact with moist and potentially infectious body substances. All of a sudden, glove use increased, and the prevalence of positive patch tests to rubber chemicals also increased in parallel. We figured it out in generally or throughout the world, and it's stabilized. And this is just food for thought whether we'll see a second wave. I mentioned the isothiazolones quite a bit, and this is an international conference, and we saw epidemic rise of the prevalence of methyl isothiazolone across the world, different countries and areas dealing with it differently. But I want to point out that testing with the MCI-MI Cathon patch test will probably render a lot of false negatives. Patch testing to higher concentration, about 0.2%, is necessary. And we note that our European colleagues, being very quick on recognizing this and doing something about it, banning it largely in leave-on products, has resulted in a major reduction in the prevalence of positive patch tests and contact dermatitis to isothiazolinones. We see them widely in our industrial uses, and for example, nearly all water-based paints contain methyl isothiazolinone. And here's in case a patient with recalcitrant hand dermatitis, patch tested to a standard series. Notice the yellow on the upper left, negative to the 100 parts per million of the MCI-MI, but positive to the 2,000 parts per million on the lower right. And in fact, this emanated from hand emollients, cleansers, and surface cleansers that were being used in their workplace. I mentioned fragrances a little bit earlier as a recurrent theme, as important items in hand dermatitis. Fragrances are remarkably common during patch testing. More than 1 in 5 people who we patch test to a large enough number of fragrances react to them in botanical extracts. They're common in women on the face, legs, and anogenital area, but hands as well. The reason these are complicated is they're so ubiquitous. There are thousands of fragrance chemicals available for use in personal care products, and the sensibilities of what smell good tend to change with time. Now we're seeing commonly chemicals like linalool and limonene, particularly in their oxidized form, lyral, and natural extracts like tree moss and oak moss being common fragrance allergens. Cleansers are complex items that constantly touch the hands and can frequently cause hand and arm dermatitis. There's a large number of allergens in cleansers that can do it, namely the surfactants, the preservatives, and the fragrances. And I would just call out, in 2017, the alkyl glucosides were named Allergen of the Year by the American Contact Dermatitis Society. Here, a patient of mine reacting to amidoamine or cocamidopropylbetaine from a cleanser that they repeatedly used on their hands. And lastly, one kind of interesting and difficult to diagnose issue. This patient presented to me with fingertip dermatitis and some dermatitis on the palmar surfaces. She came up positive to nickel, felt that foods were very important and provocative, particularly soy-based and chocolate parts of her diet would make her worse if she ate a lot of it, which makes us think of systemic allergic contact dermatitis. Of course, non-contact exposures through parenteral routes, through oral, intravenous, other GI or injectable routes, and nickel often described as a provocateur for dyshydrosiform hand dermatitis when the diet is high in nickel. So just to conclude, the allergens that cause hand allergic contact dermatitis still are our most common allergens that cause contact dermatitis in other sites, right? We see the metals listed in the top 20, the preservatives, the fragrances, and the rubber chemicals all listed very high in the most recent North American contact dermatitis study. So to conclude, hand dermatitis, very heterogeneous group. You're going to hear that throughout the whole symposium today. Treatment rests in trying to detect the provocative causes that may make this hand dermatitis worse or recalcitrant to disease. Even corticosteroids that we use as treatment may be the source of the allergens. But patch testing is an important tool and one we ought to consider frequently when we have patients with difficult to treat and moderate to severe hand dermatitis that can perhaps give us some insight into the cause of their dermatitis. Thank you so much for your kind attention.